Moving forward to our next talk of the session, which is on clot formation and bleeding in advanced liver disease, please welcome Dr. Mathis Heydtmann, who is joining us from NHS UK, a consultant hepatologist and honorary associate clinical professor at University of Glasgow. Dr. Mathis brings a wealth of international experience. He will be guiding us through a complex and often misunderstood area, understanding clot formation and bleeding in advanced liver disease. Dr. Mathis, the stage is yours.
Thank you very much. So I don't want to rush through a lot of trials, and I want to slow down and make sure that you are aware of several very important contexts to understand bleeding and clot formation and cirrhosis in general. So 2 years ago I gave a talk on fatty liver, which we know and are an important risk factor for clot formation, as we've just heard. And this is the background of my talk today. So briefly, before I talk about the clot formation and bleeding, some of you might remember that I've presented a talk in my talk about a patient who had fatty liver disease and had abnormal tests 10 years before he was diagnosed with a dramatic hospitalization through A&E to our hospitals, presenting with decompensation. And at that time, he had a variceal bleed, he had thrombocytopenia, and abnormal clotting with an increased prothrombin time. So talking about fatty liver, there's one update. So this week, there was a proposal made to the executive board of the WHO to include fatty liver in the non-communicable disease priorities of the WHO, which will be voted on in May. And this will be an important step to deal with the epidemiology of metabolic dysfunction in general, and your support is very much appreciated. So as many countries as possible should vote for that. In my talk last time, I talked about the functions of the liver, and of those functions in general practice and A&E, we only measure two, which is synthesis. So prothrombin time is a marker of liver synthesis, and an increased prothrombin time is decreased synthetic function. The other marker we measure is excretion with the bilirubin. The other component of clot formation and bleeding that's important is the platelet count, and this goes into all simple and complex estimates of liver fibrosis. So the higher the platelet count, the lower the platelet count, the higher the risk of the patient having fibrosis, and it's an early marker. So this is the most simple risk factor that is commonly used, FIB4, but also in more advanced risk factors, the liver risk score, the low platelet count goes in. This particular score is very good because it also highlights the other risk factors of the metabolic dysfunction, fasting cholesterol and fasting glucose. So coming to clotting and clot formation. So there is this urban myth that the coagulation screen is useful in predicting bleeding, which it does not. And there's the myth that a normal clotting test excludes bleeding disorders. And that's a myth as well. And that is because clot formation is far more complex. So you have to have some tissue damage, and then the repair of the vessel wall occurs with platelet aggregation and fibrinogen clot formation. So this goes in several steps, and that's the normal mechanism. So after vessel injury, there's vasoconstriction. Then you get a platelet plug formation. The platelets get activated. Then follows the clotting cascade. So that's the intravascular cascade. And at the same time, there's also cascades and factors leading to thrombolysis to prevent downstream clot dislodging and formation. So this is very complex. We've seen a simplified slide by Dr. Yo. So basically the important thing is what we measure with the prothrombin time is the common pathway here in green as a marker of liver function, and we don't measure the whole clotting cascade. Also, in addition to the procoagulant factors, we've also got anticoagulant factors, and there's a balance between those two in a normal steady state, and that is very important. As I said, some of the factors are produced in the liver, and this is true for procoagulant as well as anticoagulant factors. And in liver disease, chronic liver disease with liver impairment, all of these factors will be reduced. In addition, there are factors that are produced outside the liver, anticoagulant factors such as thrombomodulin, protein C, von Willebrand factor, and tissue factor. And it's in particular the von Willebrand factor which is upregulated in liver disease quite significantly. So if you think of this balance and what we measure, so when we measure prothrombin time, we don't get the full story. So in the top row, the factors that are produced in the liver, bottom row, the ones that are produced outside the liver, we only measure the procoagulant factors produced in the liver, which is only a small part of what is important for clot formation and bleeding. And obviously, as the procoagulant factors go down, the prothrombin time goes up, and as an additional effect in cirrhosis, the anticoagulant factors go down, and importantly, the von Willebrand factor increases significantly. So if you think of this fine balance, we've got a lot of downregulation of all the anticoagulant factors, and some of the procoagulant factors are upregulated, some of them are downregulated. And even in the platelets, the anticoagulant factors are downregulated. And this worsens as liver disease worsens. So you will remember the Child-Pugh score. So the higher the score, Child A on the left, Child B score in the middle, and Child C score on the right, the more effect you get on the clotting system. Now, you see that in Child C, you can get bruises and bleeding. This is not due to abnormal clotting factors, so this is more to tissue, skin friability. And in Child C in particular, you have significant reduction of all anticoagulant factors and an increase of procoagulants. And the effect of that is that patients with cirrhosis are at risk of thrombosis much more than they are at risk of bleeding. The other effect is that because all the factors are reduced, or the net effect is on both sides of the balance is that the factors are reduced, those people with advanced liver disease have a rebalanced clotting system at a very low level, and they therefore hit rock bottom quicker, and that leads to disseminated intravascular coagulation. So a very friable state in advanced liver disease. If we think about the other components, so the platelets, after vascular spasm, the platelets get activated by getting in contact with exposed collagen, the activation then leads to release of chemokines attracting more platelets. Here's a view of the activated platelets on the left bottom. So they get spiky to attach to the vascular walls. And if you think of liver disease, the platelet count is reduced. If you ask a hematologist about that, they often think about hematological conditions like immune thrombocytopenia. So if this is on the x-axis the age of the platelets, and on the y-axis the number of platelets, there's a reduction of old as well as new platelets. However, in liver disease, the decrease in platelet count is due to the spleen getting large, and you get thrombocytopenia from older platelets being taken out of the circulation. So what you end up is with a very young platelet population, which is far more activated, despite the low number, and they are more procoagulant because of the decrease in anticoagulant factors in the platelet granzymes which get released. So again, promoting procoagulation and clot formation rather than bleeding. So we thought about it the wrong way around all the time. Why is that? It's basically because we've seen it for centuries. So if somebody bleeds, whether they've got liver disease or not, that can be very dramatic. But if somebody develops a clot, this is a silent killer. And it happens despite people having bruises and signs which would suggest that people are bleeding. So this is not new knowledge. Even in guidelines over 10 years ago, this was known. And for example, in the AGA clinical guidelines on cirrhosis and coagulation, says that commonly utilized thresholds of INR and platelet correction are not supported by evidence. Guidelines I was involved in 2020 for liver biopsy also state that the effectiveness and risk of platelet transfusion for platelet count less than 50 have not been established but can be considered. So you can see that this was a compromise between people like me who are very aware of the differences between clotting in liver disease and other people like radiologists who were slower in adopting this knowledge. Also from these guidelines with regards to clotting factors, we said that we recommend FFP should not be corrected in an INR less than 2. And again, this is a compromise prior to liver biopsy. And this was a strong recommendation. So what happens if you give FFP? Basically, in most patients, you do not correct even the INR, never mind the clotting. So you don't have any effect on clotting. The last and a bit newer concept I want to convey is clotting and microclots in the liver lead to progression of liver disease. And that is in fibrosis, you've got microvascular remodeling, you've got a distorted architecture and endothelial dysfunction. So this leads to shear stress and clot formation, microclots. And these intrahepatic microclots lead to parenchymal extinction. So basically liver tissue dies and this is replaced with fibrosis. In addition, the platelet activation, which is prothrombotic but also pro-inflammatory, also leads to fibrosis progression. And this is the only trial I want to mention, and that's relatively new, came out a couple of months ago. So we knew that for some time, but there are now studies, and there will be more coming out, that anticoagulation prevents progression of liver disease. So this is rivaroxaban to prevent complications of portal hypertension. So this study shows that anticoagulation in chronic liver disease, so in cirrhosis, prevents worsening of cirrhosis and increases survival. And that is statistically significant after less than 1 year. So I'm glad I'm a bit ahead of time. So I hope I was able to show you that coagulation should only be interpreted in the context of severity of liver disease. If the coagulation is abnormal, people are at risk of clot, and you need to worry about them dying from clots rather than bleeding. And with regards to platelet counts, the lower the platelet count, also the higher the risk of clotting, because it's a sign of advanced fibrosis. And the low platelet count is a very early sign of progressing fibrosis, and that's why it is included in literally all fibrosis estimates. And with regards to synthesis, is only one of the 2 functions we measure in liver disease. Prothrombin time is a marker of liver synthesis function, but not of clot formation or bleeding. If you see abnormal clotting factors or low platelet counts, don't think of bleeding, think of the silent killer, thrombosis. So my key messages: abnormal prothrombin time is a marker of severity of liver disease only, and decreased factors indicate a prothrombotic state, and platelet count is low very early in chronic liver disease because they're highly activated and prothrombotic. Thank you very much for your attention.
Thank you so much, Dr. Mathis, for deep dive into the hemostatic balance or imbalance within the liver disease.